Hi, everyone. Welcome to the Open Nurses Psychedelic Chat. I am Andrew Penn, one of the co-founders of Open Nurses, and it's my pleasure this evening to be talking with Shannon Dames. Dr. Shannon Dames is a third-generation immigrant to Canada with mixed ancestry from Britain, Norway, and Germany. She serves as a mother of two. I like that she serves as a mother of two. Also as a health professional investigator, a registered nurse for the last 20 years with a doctorate in education and a master's in public health. She is a professor of nursing and chair of psychedelic-assisted therapy at Vancouver Island University, or VIU, and a clinical lead for psychedelic therapy and addiction medicine clinics on Vancouver Island. She was the spearheading founder and current team member of the Roots to Thrive program, VIU's Psychedelic-assisted Therapy graduate certificate education program, and I'm going to mispronounce this now, Mawt Centre for Psychedelic Research. And I can't wait till she corrects my pronunciation on that. She and I were co-authors on a recent American Psychological Association publication, Deliberate Practices in Psychedelic-Assisted Therapy, and we'll be talking about that among others. So without any further ado, let me welcome Shannon onto the podcast here. Okay, there you are. Hey, Shannon.
Hi.
Nice to see you all the way from Vancouver, where it's undoubtedly wintry.
Rainy, yes. Yeah.
Rainy. Excellent. Well, really great to have you on here. You know, as we talked about, you and I met working on a textbook, which we'll undoubtedly get to. But before we do that, I would love for you to take a minute and tell us how you got here. What brought you into this space of psychedelic nursing?
Yeah, great question. And really just before I launch into that, I was talking to Wendy a little bit about how great it is to have a platform for nurses. It's kind of rare and really needed in terms of how nurses can serve in this field. It's really, I think our scope is pretty perfect for it in many ways. And there's a lot of work to do to kind of understand how we fit that scope into this kind of non-ordinary world of ours. And really honored to be, representing in that way. How to get into this? Very bit through a side door, like many in this space. I started down the personal road, probably at least 10 years ago now. Have spent many years neurotically running around in survival mode, both in the workplace as a nurse and personally as well. Got a nice high ACE trauma score that I've spent a lifetime working through. I came into psychedelics really as actually after I had my two babies, who are now 12 and 13, as a bit of a I've tried everything else, would consider myself, or the system would consider me probably pretty treatment resistant in terms of just like the PTSD impacts. And psychedelics, I had heard about them. I had a few friends that had explored and had, they made a dent. Instead of graduating from my doctorate, I graduated from my doctorate. Instead of walking across the stage to celebrate, I decided I wanted to walk across Peru instead and try ayahuasca at a reputable resort down there. And it was, the beginning of something. I have remind myself, and which I now know as an older, wiser person, and many others who are coming into psychedelics, that was like a bit of a crack of light that I've really had to expand over the years. It's not a magic bullet, but they're very powerful medicines, and I'm really grateful for what they've opened up personally and professionally as well.
Yeah. So I would love to hear you tell us about the work that you're doing up there in Canada. And as people are watching this, if they'd like to just let us know in the chat where you're watching from, because we get an audience. We have people on the mailing list for Open Nurses that are in pretty much all corners of the world these days. I think I got a request from somebody in Rwanda recently. So we have widespread. So if you're watching this live, and not on the live stream, feel free to just comment where you're at. But would love to hear about the work that you're doing there at VIC, VIU rather, and and how that fits into all of this.
Yeah, and so we, I think, similar to you, Andrew, are in Canada. There's a lot of demand for trying to find some like standardized guidelines and ethical standards for like how we do this work. And Vancouver Island University is on Vancouver Island, as you can imagine, and the culture here has there's a real reconciliation focus with First Peoples, Indigenous people here on the island, and really trying to understand how we focus on reconciliation and even how we deliver healthcare and how we view what it means to be healthy and in relationship with ourselves and the wider world. So the Vancouver Island University program is, it's twofold. One, it's looking at trying to contribute to the development of the field in the kind of Western world, and also really looking at, how do we honor other ways of knowing beyond the kind of colonial approach, and really recognizing that, all of us at some point in our lineage were Indigenous somewhere and carried Indigenous ways of knowing of our own, before immigration and all the colonial aspects came. So how do we really honor the nature of these medicines from where they came from thousands of years before we even got here, and what aspects might help us in the Western world understand kind of like the spiritual and energetic components that we often don't, feel into, learn about, train in, and often are kind of big blind spots in the Western way. So that's been a lot of the focus here on Vancouver Island is really trying to like come at it from a like culturally responsive and humble way, feeding the system what we need to feed the system, because we all know that's important to create bars and safety standards, and also to not be overly limited by the rather narrow view that many of us have come from.
And your role in the education aspect. So you're a professor. What do you teach, and where do psychedelics enter into that?
Yeah, thank you. So like yourself, I've been a nurse in the nursing field for I think it's been like 22 years or something. It's like half my life at this point, a little less than half my life.
Yes.
Yeah. Hard to not like overly identify when you've kind of grown up in a field in many ways. So nursing professor is where I really began at Vancouver Island University and still kind of hold that. However, most of my work, I'm the chair of the Psychedelic-assisted Therapy graduate certificate program, which is it's a graduate program for those that already hold a degree somewhere and ideally have a decent amount of kind of mental health experience, or carry kind of like a knowledge carrier identity. And it's a one-year course that's part-time. So we really work with a more of a mature audience for the most part, those that tend to already be working. It's community of practice driven, which means we kind of do everything in groups. We practice in groups, and it's three theory courses and a practicum course at the end. Which is, also tricky too. Finding areas to practice that are regulated in a rather undefined field and unregulated field is probably our biggest challenge. And I think many of the biggest challenges for a lot of training institutes out there.
Yeah. So this is a program not necessarily just for nurses. This is for any clinician or traditional carrier of these.
Yeah, in fact, I would love more nurses to come in. It's something that I love about the program is in its community of practice or small groups is kind of where all the work is done. It's a multidisciplinary group. So a lot of the work is really looking at like how do we teach each other essentially from our unique slivers of where we come from, personally and professionally. So that includes physicians, nurses, knowledge carriers, social workers, registered therapists, non-registered therapists, somatic energy providers, occupational therapists, like, yeah,
Okay.
spiritual healthcare providers, you name it. Yeah.
And is this a program that's sort of in preparation for an eventual um, legal available medicine in the sort of Western paradigm, or is it medical model, or is this where let me ask a better question. Where do your graduates go to after that?
Yeah, great question. It's mixed. So some people that have come in have been practicing in the underground for many, many, many years, and they're really looking for kind of I'm messing with my words here because it's not the word I'm looking for, but kind of like to legitimatize a practice
Uh-huh.
that already exists, and
Mhm.
legitimatize from the system standpoint.
Mhm.
And because it's a university and they're accredited credits, and so it's a certificate, it holds weight.
Uh-huh.
Um, we also have folks that have worked in mental health or spiritual care areas that are just deeply curious about how to expand into psychedelics, kind of in addition to their current practice. Um, and we don't tend to take too many like brand new folks. And then if we do, it's really looking at how their prior life experience has prepared them for this. And this is, I think, some of the challenge for the field in general, but it is training folks from so many different ways of knowing, and really making sure they have like a solid foundation, so that we're kind of building on the specialty, like giving them a bit of an advanced practice in a way, rather than teaching them like therapy 101 and
Uh-huh.
relational practice 101, and how to regulate thy body 101, although we do a lot of that. Yeah.
So you mentioned the challenge in teaching people this stuff is that there isn't really an opportunity to practice it. So when people ask me about these training programs, and there's, say, a nurse or something, I say, well, if you'd gone to nursing school and the first time you saw a patient was after you graduated,
Mhm.
what would that be like, right? And
Mhm.
and I'm wondering, and I know different schools will do different attempt different ways of sort of at least experiencing it personally. So breath work or ketamine or something like that. But that's different than actually practicing. Like that's more like being in your own therapy versus like doing therapy for somebody with somebody else. How do
Yeah.
you guys address that in your program?
Yeah, yeah. Well, it's funny. I've had more than one person from the university suggest, "Well, can you guys just do like simulation labs?" It's like, I don't know if that really works in this field. It's and that might be something in the future that we figure out how to use in a way that is a bit more helpful. It's preparing people for the rather unpredictable nature of kind of non-ordinary spaces is, yeah, you're right. It's a big challenge. In BC, ketamine is, and I know in the States too, it's become pretty commonplace. So
Mhm.
yeah, a lot of our students work with psychedelic doses of ketamine with regulated providers. So there's kind of some decent practice opportunities working with that. We also have special access for psilocybin and MDMA up here. So as much as people are like, well, you guys are a bit early in the process, we're really not, in the fact that we do have legal access to them now, and a huge void in having any form of training that is required to offer it. So I think it's a bit of we're maybe a little bit ahead of the curve, but in some ways we're also like quite far behind.
Interesting. Yeah, we had Bryce Koch from Vancouver on a few months ago, and he was talking about some of the access programs that exist there. I suppose if you can petition the Canadian government um, to try these things if other things have not worked. If I'm remembering right, is that accurate?
Yeah, and there. I mean, it's a process. Like it's a bit of a bureaucratic headache to get it all approved. But they do happen, and it really is about time and investment. There's also the reality. I'll maybe speak from where I'm at here on Vancouver Island. I often say I think we might be the psychedelic capital of the world. I'm not sure that's really true, but there's a lot of folks practicing with psychedelics in the underground, our underground as in unregulated spaces. So there's also a bit of a sense of responsibility that folks that are, entering into that world have resources and even kind of consultation with other professionals, so they're not practicing in isolation, and that they are standing on some principles to keep themselves and others safe.
Okay, got it. And then, do you have any psychedelic content in your when you have your nursing professor hat on? Because it sounds like you have sort of two different roles. What do you teach in the? Are you teaching in the School of Nursing there?
Well, since I've started doing the chair program, I'm not actively teaching in the nursing program, and we don't have any psychedelic kind of informed courses in nursing here. However, I think a lot of the professions and the trainings are incorporating the awareness of it. I would say I think it's probably very rare that there's an incorporation of how one's scope of practice moves within the field of psychedelics. Even speaking to some of the meetings I've had with regulatory boards, I think it can be pretty paralyzing for some of these kind of colleges boards to really create some lines and guidelines, purely just moving into that kind of non-ordinary space and that kind of novice guideline nature. I think a lot of professionals are left with pretty minimal guidance from their professional organizations and in their training as well.
Yeah. And so looking sort of specifically at nursing, what sort of issues have you run into with this idea, say in your faculty meetings or in the curriculum development? Is there interest from your colleagues around this, or is it approached with more kind of trepidation?
Interest for sure. I think it's becoming, there's just all of us really moving from like the war on drugs and some of the culture that has created, and a huge challenge with overdoses and like the amount that's kind of impacted and all of us in North America and beyond. There's a lot of trepidation, I think, and I'll say specifically for mental health conditions, including addictions, on like offering a substance to folks that kind of grapple with, and addictions is obviously the easiest one to say. They can be quite effective in treating addictions, but it's a bit of an example of the some of the inherent, seemingly contradictory approaches and a bit of that black and white thinking around kind of how we move and what kind of first line therapies are really effective for treating those things. So that's a long way of me saying I think it's a bit of both. There's a lot of interest, and as much as I say, like, I think there should be more nurses in this field, and I really do think there should be a lot more nurses in the field. I also think our training, it supports it in the holistic umbrella, like for sure. I'm not convinced. I think, and I feel like I'm getting at myself in a little bit of trouble here saying this, but I'm going to say it anyway. I think a lot of nurses are trained, to be kind of alarmist. Like we were in some ways like the last check, right? So having like a lot of order, and we tend to be a bit of a neurotic folk because of it, like very, hypervigilant in the surface world, in the ordinary surface world. So having another practice where it requires us to be more energetically attuned, to move more fluidly, to like really listen to our intuition without like super clear protocols telling us exactly what to do when this happens, how to respond. I think it'd be really tricky too for nurses to like feel like safe and confident and to not feel like they're going to get, shamed, which there's a lot of shame in our culture. I think it's how we kind of march to a very similar drum, look, talk, walk the same. And in psychedelics, there's more risk involved and more trust in our own intuitive capacities to move with integrity, and to not always have like the right answer to respond. Yeah.
Yeah, I'd love to dig into that. I don't know if you saw, there was a paper that I think her name is Anna Grafe at the University of, I think somewhere in Minnesota, paper just this last week saying it was I think in the Journal of Nursing and Mental Health, saying that I think 78% of the people they surveyed had some interest in psychedelics, nurses that were interested in psychedelics, but only about 12% felt like they had any competency or understanding of it. And so there's this big gap between sort of interest and how would you actually implement this. So I'd be curious to get your thoughts on what you touched on this a little bit, but I'd love to dig in a little more. Like, what do you think we have to unlearn? What do nurses have to unlearn in order to do this work well? And then maybe once we figure out what we have to cast off, we can talk about what we actually need to add on. But what do you think we have to slough off first?
Yeah, it's a good question. So I was just met with a nurse earlier today. I was also a student in the program, and we were talking about the same topic around, some of her just challenges on trying to figure out like how she would transplant her training and knowledge from nursing into the field of psychedelics. Like on the surface, our scope covers a lot of it, right? Like we can administer medications, we can do assessments, we've got the relational practice and the ability to like touch bodies and have training in that and have good ethical standards to really give us like a really broad scope, especially nurse practitioners like yourself. You've got the prescriber card there as well. It's like full scope. So lots of opportunity. And I think there's a lot of, based on my experience talking to nurses, there's a lot of hesitance in terms of, how do I practice without like a protocol? There are protocols in psychedelics. I know through the nonprofit I work for, Thrive, we have a lot of protocols that it provides the order that we need for consistency and, making sure that we're all moving in a similar way, which also builds confidence and security in how we move. But it's not the same as like a protocol that you might have in a typical healthcare setting. That's a bit of a like checkbox, do this, do that. It's like more doing focused. In psychedelics, it's so centered on the like relational therapeutic alliance and feeling your way into, when do I lean in? When do I lean back? How do I support the body when it's dysregulated? How do I support my own body when it's dysregulated? And I'm bringing that into a field with somebody who's very energetically vulnerable. And I think these are some of the unlearnings on the nursing side, is that focus on check boxes and doing. We're trained in the being and knowing, and I don't think there's been a lot of focus put on it in our training. There's also, I mentioned earlier about the amount of, there are certain fields that have a high amount of social shame in them. And a lot of those fields are the ones that, where the risks are very high. And it means like the doing world needs to go like lots of checks and balances and making sure everyone's doing it the right way. And it creates a fear and a real hesitance to trust what the body is telling us, like how to move. Because we're more comfortable trusting in what we've memorized, what's on a piece of paper telling us to do. And that won't help us be, there's an aspect of safety that provides, but there's a very big gap in safety that we miss if that's what we're kind of hinging on.
So if I'm hearing you right, the fear drives a kind of leaning really hard on protocols and like, what are you supposed to do now? I mean, I'm thinking about like, I don't know, something like ACLS, right? You're running a code, like there's a very prescribed, nobody does a code by intuition. Like if you did, it would probably be malpractice, right?
Totally. Yeah. So, and God forbid you make a mistake in there, right? Like the stakes are very high, and we watch each other and ensure everyone is following a very linear path.
Right. So that's sort of an example of on the extreme of something that we do, that it's expected that we do that in a very particular way and we follow a certain path. But what you're saying is that there's an intuitive judgment piece here, which, if I think I'm understanding you correctly, you're saying that that's part of what makes nurses uneasy about this sometimes, is that, I mean, have we lost our connection to intuition in our training? I mean, we're both educators of nurses. I'm just curious, do you think we've sort of somehow trained that out of people?
Well, I would be curious. You and I don't know each other super well, but I've often wondered in this, like, I want to say earlier waves of psychedelics, and it was not an early wave of psychedelic. It's more like a relearning based on forgetting after a few generations. But in this early Western medicine wave, it feels to me like there's certain personality types that tend to go in, and in particularly nurses, like those that have a little bit more, maybe like a wider window of tolerance, more capacity for chaos, and being able to kind of make decisions and like that, like gut, like a pretty well honed gut or instincts. And I think those tend to be some of the leaders right now in the nursing world. And it's like prototype. So for us to be able to like expand that prototype and bring that kind of wider window of tolerance and those intuitive capacities to the wider field of nursing, I think we definitely have some work to do. And maybe just to add to that piece, as more of a tangible example. So I work at the VIU program. I also serve in a nonprofit that takes practicum students. And our biggest risk, and I know it's going to sound really odd, but we have nurses coming in that are meticulous on the surface, right? They don't miss a beat in terms of like the paperwork and making sure they've got all the ordered bits in place. And some of those same nurses will walk into the room with like anxiety levels that are like 12 out of 10, just vibrating. And it creates a lot of nervous chatter, and we're bringing in participants who are also quite nervous, and we really need to downregulate them so that they actually are like in their bodies, not like cut off at the neck and living out of their heads. That's really important because we can't actually integrate insights that come in at the level of the mind. We can memorize insights at the level of the mind, but we can't integrate them unless people are learning them at the level of the body. And in order to do that, they have to be like, their nervous systems have to be calm enough, trusting enough, that they can, take it in at that level. So if we've got providers, space holders that are coming in and they're like right up there, it actually pulls participants up there with them, because it's a bit of a signal. This space isn't safe. You can't trust yourself. You can't trust the people. It's like if the providers have their threat radars right up there in like neuroses mode, we're going to pull the participants into that mode as well, right? Because they tune in according to us. So it's our biggest barrier with nurses, is like helping them know what it feels like to be in a regulated body, to like feel safe and secure, not like big ego, and we still need the humility and all that, like open learning, but that we feel safe in our own bodies on a day-to-day practical basis, and that we can bring that degree of safety into those rooms.
Interesting. And I want to encourage, as we're talking here, if people in the audience watching us live want to ask questions, to please feel free to put those into the comment section. We'll get to them a little bit later in our conversation. But it's so interesting. I think about, when my wife and I fly places, like I'm a fairly calm flyer, and she tends to run a little more nervous. And so when there's that jostle of turbulence or something, often I get kind of like fingernails into my hand. And what I do, I look at the flight attendants, because I figure if they're not panicking, they do this all day long, right? So, if they're like, oh yeah, it's always bumpy over Denver, like no big deal. But if they look like they start shooting glances at each other, I think, oh, maybe there's something actually to be worried about here. And I'm thinking about your nurses, right? If somebody comes in and the subject is, patient is already feeling a little anxious, and then they pick up anxiety, that I could see where those two would definitely, and you could have exactly the opposite effect. If, you're feeling anxious and somebody says, we got you, you're going to be okay. That has great power.
Yeah. That's such a good example. Yeah. Yeah.
So do you think that, I don't want to belabor the point too much, but I really want to, I feel like you're onto something that, I've tried for the last, 5 years since we started this organization, kind of feeling through the experience of how nurses respond to this. And obviously we've selected for a group of people that are really excited about it and probably naturally kind of drawn to it. But I definitely encounter that, like, oh, I don't know, and it's not as simple as just, oh, these were drugs that were listed in my substance use textbook as bad things, right? It's deeper than that. And I think you're getting onto something about the sort of having to rely on something other than this kind of left brain, logical, linear, if A happens, do B kind of model.
Yeah. And I think the reality of the statistics, even with, it's not uncommon for clinicians and therapists to, be more haunted by trauma than the patients they're serving. We're in a trauma-laden field, and especially now, the mental health statistics are alarming, and they're worse than healthcare providers. So it's a bit of a, like, looking in the mirror too on, how do we work with our own healing on this, and it's not a one and done. It's a way of living, and really reconnecting with our own sense of meaning and purpose and safety in the world. It's not about, I think I'll speak for myself. A lot of my life has been about, if I can just get the right letters and the right job and the right title, and then I'll be okay. And it's kind of the opposite in terms of, like, how we move in psychedelics. We leave those labels at the door. We leave those credentials at the door when we're doing that healing work. And as providers, we really ask, whoever you are and however you're holding space, that we don't lean on those credentials. That's it's really about doing your own work and knowing enough about yourself and what your center is, that when you're off center, right? So then when there's times in SITs, not even that long ago, where I've had to communicate with those I'm with. I was like, I can't touch anyone today. I can be a guardian at the door. I'm going to kind of just manage my energy from the outside. I got too much going on. And that's not a hit on me, actually. That's just like self-awareness. And I feel safe enough with the team that we can communicate like that, so that energetic side, which in the non-ordinary spaces is actually a really big aspect, is something that we actually talk about, and that we're self-aware enough to be able to talk about that. Really, really important.
Yeah, and so often in nursing, we really kind of valorize not doing that, right? So, you're on the floor and say, "Oh, I'm doing a double," or like they'll joke about nurses' bladders, like we wear, not peeing and getting UTIs as some kind of like badge of how dedicated we are. When really, when you step back, you're like, that's kind of messed up, right? That we would even think that that's something to be proud of. I mean, it's a necessary. The systems we work in are exploitative.
Yes.
Right?
Yeah.
So the reason why you're eating, graham crackers and Jello out of the patient pantry, because you haven't had a dinner break, is because there's nobody there to give you a dinner break. So you just push through.
Yeah. Yes. And it's part of our conditioning, and it's that idea of, I think I've keep saying that word shame, and it's a hard word to swallow, but it's a lot of how we've been raised. Like I grew up in nursing in many ways. Like I went in as a very young adult. A lot of like how I learned to view the world and take care of myself, was conditioned in nursing school. And as a young nurse, and learning to just kind of like suck it up and toe the line, no matter what the heck's going on in my body at the time or how I'm feeling, was kind of a necessity. And I think we carry that into our field and how we treat each other unconsciously. I didn't think any of us would consciously be malicious or sling shame at somebody for who's having a moment of self-compassion. But unconsciously, I think we do it all the time,
Yeah. Did you see the paper that came out last week from University of Washington, Tony Back's paper about psilocybin treatment for COVID-19?
No, tell me.
Oh, well, for those of you watching at home, we have our winter newsletter should be coming out probably first thing in the morning. And we have links to both of these articles, both the one I mentioned earlier and this one. No, they studied Tony Back is a psychiatrist, I believe, does a lot of palliative care work at University of Washington. A lovely guy. And along with a couple of nurses on his team and some other colleagues, they did a study of, I believe they ran 30 subjects, healthcare workers, many of them nurses, who were experiencing depression following their work with the COVID pandemic, and looking at kind of this moral injury. But there was a line in there, and I can't remember exactly what it said, but qualitatively talking about, yes, we'll drop the link in the chat, talking about the injury that people experience and the feeling of like betrayal by healthcare systems. And and a lot of times, I love your thoughts on this, but what I often see when I work with patients is that sometimes there's originally kind of an external anger at a system that took advantage of them, whether that's their family or their employer or their partner or whatever. And then underneath that is kind of like maybe you said it well, shame that we allowed ourselves to participate in that, or that we had to participate in that in order to survive. We needed a job, we needed to support our families, so we kept going to this job that ultimately was inflicting harm on us, and then there's this piece where we feel rotten that we participated in our own harm, that and that's sort of what came up in this, that the folks who had gone through the COVID pandemic, because I'm thinking, wow, if that nursing as self-sacrifice narrative was really on full display, it was about 5 years ago when the pandemic was starting. Remember, we were heroes, and nurses wear capes, and and then it's like, oh well, but we don't have N95 masks for you. Sorry. Maybe you can use the one all week. Put it in a paper bag when you're done at the end of the shift.
Yeah, and you can come to work sick as long as you're wearing a mask, and like all the standards, which is really like, please get your butt in here, whatever you feel like. Yeah.
Right. Don't call us sick.
Yeah, I think there's the other risk when we have, essentially been traumatized by a system, which I want maybe to talk a bit about trauma. The way I'm defining it here is when there's an unmet need in us, maybe even a wound that happens in the workplace, or not feeling taken care of, and we're not met in that place with understanding and compassion, we can carry trauma forward, kind of like noise in our body, right? So when that's happening over and over and over again in the workplace, where we're like turning our bodies off, not listening to the signals, because there's a belief system that either we're not worthy of listening to those signals, or it's not okay. So it's a survival choice within that field to survive. You turn those signals off, and then we end up becoming really anxious humans because we got a lot of noise going on, and that creates a bunch of hypervigilance, which is all connected to PTSD, generalized anxiety disorder, all sorts of addictions and things that we do when we're grasping on external factors. And then we go from I'm a hero in the system to I'm a victim of the system, and and that's not much better, because then we have the double-edged sword of resentment, anger, and hostility, which hurts all of us, including those of us dishing it. So, and that's some of that shame too, is when we are so full of shame, like that, like not good enough, don't take care of myself, like all the stuff really comes from a place of like, I don't deserve it. I'm not worthy enough to take in that self-compassion and do those things that would be kind to myself. We will naturally spill it over to those around us. So once we're a victim of it, we start perpetuating it, right? It's kind of that like the bully cycle. And some people are really obtuse at like bullying, shaming behaviors. And, we quickly hit the bully button on those. But most of us are actually like pretty darn good at slinging hostility, shame, resentment, like all the stuff pretty unconsciously and artfully. And especially, I think, in this field and in a lot of fields where we've been relied on to be, kind of to hold those high stakes and to kind of carry that like very ordered world that others rely on.
So what's the, and and this probably ties into something I want to also ask you about, which is teaching, and the book that we worked on together, but this idea of like what's the third way, right? So if on the one hand there's like exhaustion and burnout, and on the other hand is like self-sacrifice and kind of relentless pushing forward, and a lot of times there's this fantasy that comes up of like, well, just drop out quit all of it, walk away. And like, well, that sounds great, except I, have family to support and a mortgage to pay and all those things. So it's not necessarily a luxury. That's not a privilege I have to just walk away from all of it and, go live on a beach somewhere. And I think a lot of people feel that, so they feel like, where do you see that third way? I mean, I loved what you said about on your team, you can actually speak up for that part of yours, when you are like, I don't quite have it today. Like, it's okay to say that. You're not letting anybody down.
Yeah. And I think some of that third way is coming back into connection. And that's a big, broad statement. But it's this idea of, if a lot of the mental health statistics are not looking so great in healthcare providers, with nurses like centered in that as well. And often those like mental health conditions, anxiety, PTSD, those kind of like disconnecting experiences where we feel alone in the world, and that we live in hypervigilant states where our own bodies feel very unsafe to actually like check in with and sit in for any long periods of time. We run the risk of our nervous systems running our lives. And I think a lot of us, when my nervous system runs my life on a like relatively regular basis, not saying I'm immune to that. I'm more aware of it. So, and I say it clearly, like, hey, the nervous system's driving the Shannon bus today. I'm like stepping in and out of it. But the noise is loud, and I can't consistently stay out of it. So there's just acknowledging that and being in a space where you feel safe enough that people can see you through what's going on the surface, and there's enough security there. I often say I work among friends, and people are like, well, that's dual roles and not professional, and for me, it's like that's how I stay safe. I work with people that can see me and like love me and see my gifts and my light like as they are in its true essence, which enables that surface stuff, the coming and going of the nervous system, driving in the front seat or the back seat or wherever, to come and go and not feel like my survival is hinging on my ability to be honest about that. And it also helps me feel safe. Like the moment I say it out loud, my nervous system's already like largely regulated, right? It just like, I just needed to say it and be seen by people that can actually meet me there and are not going to judge me, and they'll actually celebrate that kind of honesty and authenticity. I also say it with participants and patients, like oh, like if they're sharing something and it's hitting me hard and I'm like, having a bit of a big moment internally. And oftentimes, because other people's experiences are kind of reminding us of past stories, or my patients remind me of my mother, or whatever it is. I'm really honest about what's showing up in my body, because people can already feel what's showing up in my body. So I can say all the right words and look the right way, but if my words are wrapped with an incongruent energy than what I'm presenting, I've already lost trust.
Yeah.
So it's a bit of a like, hey, I'm humaning in this human experience with you, right? And I'm going to be like saddle up right beside you. Honestly, I'm not going to make it all about me, but it's about kind of meeting them where they're at and helping them trust that what they're feeling is that I'm acknowledging it. I'm aware of it. I'm managing it, right? So yeah, I think that's one piece, is like that, having working among, you don't want to call it friends, people that you trust, where there's some unconditional positive regard that is flows back and forth. Agreements on the team that we will hold each other in unconditional positive regard, even when the nervous system is driving the bus and our behaviors are not awesome. That we can circle back, do the repairs, and like reconnect relationally. That takes a certain amount of self-awareness and safety with our own bodies to even be able to speak. And I think we could do better in nursing to like learn how to do that, like feel safe to do that on a team.
Yeah. Assume good intentions, right? I mean, when you make it, I'm just thinking about it, something as simple as like a med error, right? For bedside nurse, I've made med errors, and in part of my mind is, oh shit, am I gonna get in trouble for this? Am I gonna lose my job over this? Like, and when you're threatening that sort of basic Maslow's hierarchy of needs, you're not using your cortex. You're not affiliative and connected and present. You're scared.
Yeah.
And so how do we create a culture that, let's start with nurses, right? Because that's our jam, that where there isn't that feeling of sort of existential threat. I mean, maybe this is a good segue to, what we attempted to do in the book that we collaborated on. Do you want to talk a little more about what that deliberate practice in psychedelic therapy? I'll put the link in the chat if you want to check it out. But can you describe what we set out to do there and how that might actually be useful in nursing education among other professions at some point down the road?
Yeah, I think actually it's a great segue, because I like a lot of that text. There's practice examples on how you could approach this and that, how you respond to when somebody prompts you in such a way, even just acknowledging transference and being aware of what's moving back and forth. And a lot of that text focuses on somatic intelligence, in our own somatic intelligence, and like really honoring that when we are moving into this non-ordinary space where we are like essentially quieting or even putting to sleep at times people's protectors, like their kind of nervous systems that are like protecting their energy field on a day-to-day basis, that gets quiet. So when that happens and we're moving in with big energy that's not regulated and there's a lot of chaos going on in our own somatic space, what is our responsibility? And how do we hold each other in unconditional positive regard and in a space of safety, where like somebody's energy might be like really off. And how do we, it's akin to like a med error, right? Like in the Western world, be like, well, a med error is like, like kind of a lot of our worst nightmare. I'm sure many of us have done it, myself included.
Oh,
and
yeah.
Like, say something? Do I not say something? Do I keep this? And like, do I report it and deal with the ramifications? But we don't ever talk about accountability of our own energy and how we move in the world. And in this field, I actually think that kind of safety is just as potentially harmful as something like giving out an extra Tylenol or something. A lot more harmful than something like that. So yeah, I think that's some of that unconditioning and reconditioning is really starting to understand where the like basic skills are. Yeah, and maybe just to add like one little piece to that around the Indigenous ways of knowing side. I think there's always a risk of like elevating Indigenous ways of knowing, and there's all these risks or talk about appropriation and all the dangers that come with kind of moving in some of that. And I like to just kind of look at it a bit like at one point before all the colonial structures were in place and we had all these like very linear ways of moving. We were all Indigenous somewhere and carried medicines. Like we were medicine carriers. Many of them women before, it all got shifted. And it's actually part of our lineage to really like move more somatically, to allow our bodies to be the guide, because through that body is a connection to spirit and more intelligence than we could ever have at the level of the mind. And in really starting to like expand a bit in our kind of spiritual and energetic capacities. And that's uncomfortable for a lot of Westerners. Like it doesn't have to be religious. It doesn't mean you're like going into shaman world or like any of that. It's really just connecting with the reality that we are energetic beings. That we can't even deny that on the science side, but how do we acknowledge it on the practice side?
So this book that we worked on, for people that are unfamiliar with this deliberate practice framework, because that may be not something that is familiar to people, can you explain a little bit what that is and how the book is structured? Because to be clear, it's not a book that you would read like cover to cover necessarily. It's more, I think of it more as a workbook in some ways, exercise book. It's not great, probably not great bedtime reading, but very useful for teaching and learning.
Thank you for circling back. I realized I went down a little rabbit hole there.
Well, that's okay.
And I think that's a lot of in this field in that book is really moving away from the memorizing facts and figures and how to do things from like step 1 to 10. And that is very much insight. That like protocols are very important, even in Indigenous ways of knowing, going all the way back. Protocols and ceremony and all is very ordered, and you stick to the protocol, right? Because deviations can lead to safety risks. So like not throwing that out. But this book is really about practicing, like really like learning how to acknowledge our own somatic bits in it. And like, for example, if you bring up something to me and I'm like listening to the words and feeling the emotions, rather than responding with something that's coming just straight from my mind, in like more of a fix it or parroting approach, it might be like, oh, when I hear you say that, I'm feeling that like right here in my chest. Oh, it feels like really heavy, So it's this like, I see you, I feel you, and I'm acknowledging what's happening right now. And in that way, it's like it's therapeutic use of self, right? So that's the practice is how do we practice therapeutic use of self over analyzing from solely the mind.
Yeah, I think one of our conversations, so this was a book that I think there were 5 of us on the writing team that you led, Shannon, which means that you did a lot more work than the rest of us. Certainly more work than I did, I'm sure. But it was the way that I think it was Tony Rosa Marini, if I'm saying his name right, described deliberate practice. It's like learning music. You don't play jazz until you know your scales, right? But once you have the basics down, then you can start to improvise, then you can start to play, and then like intuition comes into play. It's because sometimes I think sometimes intuition gets a bad rap because people use the word intuition when they mean I don't know what the hell I'm doing. And that's not intuition as far as I'm concerned, right? So this, I think what we set out to do, I mean, tell me if you think this is accurate, is to start with these very basic exercises where people try out different ways of responding, and so, and just like you would practice your scales or your chords or whatever until they become sort of second nature. And from then you can branch out, and we structured it so there's sort of easier, more difficult, most difficult kind of scenarios. I think of it also as like role playing with more of a script, because sometimes, I know when we do role plays in our training program, sometimes people either like will come up with the most challenging, ridiculous case possible, or it's too easy. It's like softball. And so this was to create some guidelines for people to do that with, some examples.
Yeah, well said. You walked that through, I think, quite well. And it's really to develop some of those intuitive principles. And there's lots of room for, and maybe this is like circling back to the nursing side. Many of us are novices in this, and I still like people like, you're an expert. It's like, no, I'm not. I'm a novice. I'm still learning. Like I'm taking it all in. I stub my toes all the time in this field, like say the wrong thing. I touch somebody when I should not be touching someone, and and like jolts them or whatever. It's like, and all of that is learning, right? Around like, how do we, as a pretty externalized field, really honor what an inner healing experience is. That's like more patient directed rather than provider directed, and it's a huge surrender to like for us as nurses who are used to being a bit more like outside in on the like do this, do that, both to ourselves and for those that we're serving, to really trust that the person in front of us has all the knowledge that they need inside of them, and they are connected to all the resources they need energetically and spiritually to know what to do. It's really about helping them remove some of those barriers so that those insights are coming from within them. We're not feeding them those insights, right? So, and I think that's a big flip for us as nurses, is like, I don't think it's our own inner healer, right? Because every time we don't live in our bodies, we lose access to that. So we're not in relationship or connected to it. And then we're going into a field where we're trying to help participants and patients like connect to theirs, but we can't actually help them do that because we're not connected to ours, right? So it's a big learning.
I appreciate that. It kind of goes back to our earlier conversation about unlearning things. A couple more questions, and then I gotta let you get to dinner and get on with your evening. So, but back to this question around the somatic training. Do you feel like this should be a requirement for nurses who are going into this space to have some kind of somatic therapy experience or training? And is there a particular modality that you particularly like, or you think it was particularly well suited to psychedelics?
Yeah, so I think actually this question is not one that can be answered really in an easy black and white way. So I'll maybe just put it out there to say, nurses, I cannot remember the year. I want to say it's in the 70s, but the therapeutic touch was coined by a nurse from New York, and I cannot remember her name. And it was quite common for nurses. And actually, therapeutic touch didn't involve physical touch. It was like energetic, more like, looked a little bit more like Reiki, and like used a lot of intention and intuition. And it was, and then touch has become more tangible in nursing over the years. And we're trained in it, but more around the like ethics of it, and like maybe massage and working with muscles and that kind of thing. So yeah, all that to say, I think it's not necessarily, and I'm going to answer this in two ways. I think the field of psychedelics is becoming highly commercialized, like, and it scares me a bit about like how much it's like, we're just like creating a business off of psychedelics. In Canada, it's not, we have a lot of business in health. That does happen, not nearly as much as in the United States, because that socialized medicine as healthcare as a basic right isn't as, it's more of a thing up here. But yeah, so I, when people say, do you recommend trainings? There's also part of me that's like, does not want to promote this giant commercialization of every skill you can imagine, and signing up for every training you can imagine. I really look at it as like a really good start is learning how to sit in your own body. And just like noticing what's there, like mindfulness is a good practice. Like becoming more resilient. And what I mean by that is like being able to move in the world authentically. Like what you see is what you get, obviously with some decent filters in there. So we're not, causing harm when we're not in our best state. But like really like focusing our own security in the world and safety and like getting our, in alignment with purpose and meaning. And that is one of the things that makes us the safest in when we're touching people. And we know what it feels like to have a very calm, centered, secure energy. And we go ahead and touch another human, they feel that calm, centered, secure energy. And how you touch them and what patterns that looks like and all that, those are great skills to lose. There's lots of great programs out there. I've taken a few myself. But like just go right back to the like, it starts with just knowing myself and really feeling into like what's going on in your body. And from there, great, learn some tools and tricks of the trade. But I think that's honestly just the best place to start.
Yeah. Don't just do something. Sit there.
Which is hard for us because we like to do things.
It is. It goes back to that unlearning piece, right? Because, I think most of the time when we're working, we're thinking, okay, what do I do now? How do I respond to this situation? Do I need to go check the orders and see what med needs to be given or whatever, instead of just like, just hang tight for a second.
Yeah. Like, I'm noticing some anxiety there. Like, what's that coming from? What's underneath that? Which is normally not a habit for us, right? Normally when we feel that anxiety, we impulsively spring into doing mode, totally ignore what's actually happening down there because we're distracted with doing, which is easier. It's easier to go and do than it is to sit and with something that has felt like a threat for a lot of years.
Maybe because we've also associated not doing with negligence.
Yeah, good one. Yeah. And our achievements and our doing is directly related to our worthiness, which is like a big old story that many of us are standing on.
I don't know anything about that. Well, that leads me to this final question, which we love to ask traditionally at the end of these interviews, is if you could go back and give your younger self a little advice. You can choose the age, but what would it be?
Find your people. Yeah, find people that help you feel safe. And if you can't find the compassion or unconditional positive regard for yourself, find the people that can show you what that feels like. Because when we carry that, and some people call that love, that's got a lot of baggage attached to it. So I usually say unconditional positive regard. When we carry love for ourselves, and that which comes with self-worth and ability to sit in peace without running around neurotically on the surface, we have the ability to share that with others. And that is the greatest gift we can take into psychedelic-assisted therapy. Like that as a space holder to just feel that kind of security. That's a gift. And we can't teach ourselves that. We actually learn it relationally. So find your people.
Find your people. Well, that is a really good place to leave things, because I think one of the reasons why people find this organization is they're trying to find their people.
Yeah, that's a very good point.
It's one of the most satisfying things to get these emails, because I get the emails for everyone who signs up on our website. So I've gotten 2,700 of them or something. And when people say, I didn't know there was other people that were interested. I didn't know there were other nurses that were interested in this. I'm the only person I know in my hospital and my nursing school, whatever, that has any interest in this. And I had no idea that there were other people, let alone an organization. So I think it's one of the ways we find our people, for sure.
Yeah. Awesome.
Shannon, thank you so much for taking the time to chat with us tonight. I love these conversations because I never know where they're going to go. Kind of like a good psychedelic session. And so,
true point.
So if you want to share this with folks, you can certainly the YouTube link will work as an archive. And next month, we're going to be talking with Naut Thomas, who is a nurse anesthetist and psychiatric nurse practitioner in Rhode Island. And then later on in February, we're going to be talking with Jessica Fitzmaurice and Taryn Hale. You may have heard something about Jessica's story a few months ago. She is the nurse who was arrested for growing psilocybin to treat her own depression, and we'll be sharing that with the attorney Taryn Hale, who helped her navigate that case successfully. So we have some excellent interviews coming up in the future, and as always, these are archived on our YouTube page, and we look forward to seeing you next time. Shannon, thanks again for spending some time with us. Really appreciate the conversation.
Thank you. It was a pleasure.
All right. Bye, everyone.